Good morning or afternoon. This is the fifth talk in the Nebraska Quality Improvement Project Continuing Education offering. And you've been working on this project for several months, and it is probably a good time to talk about barriers that you've encountered to quality improvement initiatives, because I'm sure that you've run across some of these, and there are probably some that I won't think of that you've run across, but I wanted to spend some time talking about barriers to quality improvement today. The objectives of this session are to identify system and people barriers to quality improvement in ambulatory clinical settings, and to describe the strategies, some strategies for overcoming those barriers. I'm going to go back to the chronic care model. Often now you may see in the literature called the care model. They've dropped the word chronic, because I want to remind you of these 6 components, and that you can use this as a way to think about the barriers that you encounter. There are organizational barriers, there are decision support barriers, there are delivery system design barriers, there are clinical information system barriers, resource in the community barriers, and self-management support strategy barriers. So I'm going to talk to some degree about all of these, but I'm not going to forget that some of the barriers are people too. Now, what I'm going to do though in this session is to just talk about those first 5 components of the chronic care model, because when I was thinking about what the last 2 sessions of this 6-session CE would be, I realized that probably dealing with difficult patients would be a good last session. And so that is another barrier. And so I'm not going to talk about it in this session. Instead, I'm going to save it, the best for last, dealing with difficult and challenging patients. Let's remember, in terms of system barriers, about what organizational support requires. The system, in order for you to be really effective, you must have organizational support, and that means the system has to be willing to support QI, and that's all about release of resources. And there are 3 categories of resources that we're talking about: time, money, and personnel. And so if there's a barrier, it's because they're unwilling to support quality improvement through the release of any of these things. Now, my lived experience is that money is probably the least important of these. Quality improvement, as you might have, I hope, have already discovered, it really isn't terribly expensive, but it does take people and it does take time. And so those are the 2 things that the organization has to support. And I'm going to give some examples as we move through here of where just a little decision that an organization can make that would support a problem that is being encountered with quality improvement. Decision support is another area where you can have barriers. If you recall, decision support are the tools where you have information. Providers, all of you have information, the latest state-of-the-art information about how to do things. This includes the billing and coding people, because it's what's the newest thing and how to most effectively bill and code, but it's also the providers. And so you can have barriers if you don't have the latest state-of-the-art information about care, and if you lack resources to assist with establishing benchmarking. So you don't know how to do it, or you don't know where to go to find it out, or you don't have the data. Now, I know you all have data because that's what this whole project is about, but resources for assisting with benchmarking may be something that you are having some trouble with. Another area is delivery system design. So this is the practice management system. The appointments, the billing, the support staff perhaps are not flexible enough to allow initiative or innovative practice changes. For example, in my clinic, one of the nurse practitioners really wants, I've seen this happen so many times, they want to start putting a diabetes flow sheet in the chart, and that really requires that the check-in person do that. I've been trying to collect something we finally called hurricane forms. We won't go into it. It's been a horrible experience. But it's very hard to collect these data. And the med students, bless their heart, have a clinic on Tuesday and Thursday nights, and they just can't get the data for me. And I've really been nagging them, and they tell me that I should come and try to collect the data from 28 schizophrenic patients in the waiting room. And I almost did, but my staff took pity on me, and they started going and collecting the data. So it's hard. It's like I said, it's time, money, and people, and so people have to be willing to make changes. Sometimes it's a simple change, and sometimes you're just real busy and it's not a simple change. And sometimes the support staff just aren't trained or otherwise prepared to do the things. For example, as you well know, anybody that's worked at the front desk knows that the people skills are just everything. And I'm sure in your practices have people with severe persistent mental illness, and they can be very difficult to deal with at the front desk. And so you have to make sure that your staff are properly trained or prepared to deal with them. So those are all delivery system design examples that I'm babbling on about. I just keep thinking about those hurricane forms, and I'll be sure glad when those are done. There we go, okay. And then another thing is clinical information systems, difficulty getting the data you need to support the quality improvement projects. We started, in my practice, a great electronic health record. I was so excited. We started last November. I still don't have the data I need at all. And I'm very frustrated. And what I found out was we didn't buy it. We got open source software. And to really get what I need, I have to come up with $50,000 to get the kind of support and the kind of software I need. So I'm coming up with $50,000. Fortunately, my system is able to do that. But the clinical information system, and this is where your doc site material comes in. And even if the data are in there, which is one piece of it, excuse me. But also then, can you get it? Can you get the reports you need? So these are barriers to quality improvement. And then, of course, there are community resources. You either in your communities, you all live in very rural areas, and you may have very limited resources, and you may not even know the resources that are out there, and that could be a barrier to really providing the quality of care. If one of your quality improvement things involves diabetes education, who is your certified diabetic educator in the community? Where can you access that kind of thing? And so that's often a barrier, particularly in the rural communities that you're in. And then there are people barriers, and please know that this is not just any of you. It's not any one person. In fact, I'll really emphasize at the end about these are system problems, not people problems. But the provider and the staff may not be able to engage effectively in quality improvement for a variety of reasons. One is that they just don't understand it, or they don't have the knowledge they need. Another one is the skills. Another one is the leadership. You really need some leaders, and that's not just top-down, that's bottom-up leaders. And then a concept that I'm particularly fond of, I just think it's such a cool word, clinical inertia. Very, very common, and it's one of the main reasons. I don't know if you've ever heard, we hear all the time in our academic health center how what we know is the right thing to do takes up to 17 years to get from when science says, this is the right thing to do, to we actually are doing it everywhere. And a big reason for that is clinical inertia, and we're going to talk about that in a few minutes and how you can overcome that. So how do you even know you have barriers? What actually are the barriers to accomplishing your goals? So the first thing you have to do is, you really need to step back periodically in the process of doing quality improvement and saying, how are we doing? How are we doing? And are we really accomplishing our goals? And if not, why? And then the why, you have to really be specific and label the problem clearly. Now, usually there are multiple problems that you need to then prioritize so that you decide how to address them, and you approach the issue in the same way you would a clinical problem. So just like a clinical problem is that, your patients aren't getting foot checks, a QI process problem might be that, half of the staff aren't paying any attention, aren't doing what you're asking them to do, even though you've got this process going. So you have to, sit back periodically and say, are we being successful? And if not, why? and then prioritize which barriers you're going to, which ditch you're going to die in today, as we used to say in my old world. So I'm starting this slide with the last phrase in the slide before. Address the issue in the same way you would a clinical problem. Once you identify a barrier, you need data to verify that it truly is happening. I can't tell you how often in my practice, and I'm sure this is true in yours, I say I need the data. I have somebody come to me, I have a nurse practitioner come to me and say, oh, this doctor isn't doing this, or this nurse isn't doing that. And I'll say, give me the data. Do you have a list? Tell me how often this has happened. Give me examples, real-time examples of when this is happening. And so when you have problems in the process of quality improvement, you need data just like you do when you have a clinical problem. And so you have, and then you have to serve, that has to serve as a baseline. So if in fact, for example, the medical assistants aren't doing what they're supposed to be doing, you need data to verify that. Maybe once. I mean, it's been my experience that they aren't doing it, and they is often one person, and not doing it is often one time. And so, are we making a big McGilla out of one situation, or do we truly have a system problem here that we need to address? And so if you do have a system problem, then you've got to have the data to support it. And then that serves as your baseline to evaluate the effectiveness of what you're going to do. This should sound familiar. It's the same thing you do with quality improvement itself, but this is looking at the quality improvement process rather than a particular quality problem. So let's use an example. The Quality Improvement Committee says the problem is that the front desk people are failing to schedule follow-up appointments for people with type 2 diabetes. So in other words, you've got a thing going with your type 2 diabetes patients, and you're going to do follow-up appointments. And one of the things that's supposed to happen is the front desk people are supposed to schedule follow-ups when they check out. This is a delivery system design barrier. Because the front desk and how they perform their work is a delivery system. And so they're failing to do what you have set in place as the step. So again, the initial step is involving verifying what happens at the front desk for patients with type 2 diabetes at checkout. So the first PDSA cycle you might want to do on this would involve asking the front desk to keep a log of all the patients with type 2 diabetes and whether or not they have a follow-up appointment and when. So in other words, ask them to collect data. Are they actually, every time a patient with diabetes checks out for their next appointment, or, do they get another appointment and when is it? And so they keep a little log. Now, frankly, and the very act of asking them to do that might get them, so there's a sort of a subtle thing here, but might get them actually making these appointments. But you might find out, for example, that the problem isn't that the ladies at the front desk, or gentlemen, I don't mean to be sexist here, the people at the front desk aren't trying to schedule them. Maybe the patient's saying, well, I'm not ready to make an appointment, or I don't know when I'm going to be available, or, I'll call you back. There may be, they may be refusing to accept appointments, and that may be the whole problem. And so that means that you have to go back to first steps in the quality improvement thing and look at the whole process and say maybe checking up and doing a follow-up appointment at checkout is not the right thing to do, or maybe it needs to be the provider needs to walk them to, I don't know what, but it may not be the front desk failing to offer the appointment at all. It may be any number of things. So like I said, here's an example of a system barrier that seems to have come up. So maybe after, I'm continuing the same example, I have 2 weeks of logs is determined that only 30% of patients with type 2 diabetes are scheduled for follow-up appointments at the time of checkout. So these data do in fact verify that there's a problem, especially since the QI committee has set a benchmark of 70% of patients being scheduled at checkout. And so why aren't they scheduled? Well, forgive this busy slide, but it's just the example continued. And when you talk to the front desk, I sort of get ahead of myself. You've probably noticed that from previous sessions. You might find out that they didn't know they were supposed to be scheduling people for follow-up. So that's one thing. Or they only schedule follow-up if it's marked on the super bill. When the patient, if you as a provider don't check on the bill that you want to, super bill, follow-up appointment in 3 months for diabetes follow-up, they don't do it because they're not allowed to. And so those are two things right there, not counting the one that I already mentioned, which is the one about the patients refusing to take the appointment. So in this case, communication or training may be the issue. So that's decision support. Or it may fall back to providers to put the appointment on the super bill, which is, again, a decision support. Or an organizational decision could be made. Maybe the staff don't believe they're allowed to schedule an appointment independent of information on the super bill. In other words, they can't, if it's not on the super bill, they can't say to a patient, we need to schedule you a follow-up in 2 months or 3 months for your diabetes. And so maybe the organization, the clinic manager, needs to set a policy that says, okay, you, the front desk, are allowed to schedule patients or, with proper guidelines. In other words, you wouldn't want to schedule them in 3 months based on the fact that they have type 2 diabetes if the provider has put on the bill that he wants to see them in 1 month. And so there needs to be some guidelines. But you can see how here's the problem. You've asked the front desk, you've looked at some solutions, and you can have some intervention that involves decision support or organizational support. And I probably told you the story about my clinic, and we wanted to get everybody with asthma having peak flows every time they came in. And so we did all these PDSA cycles, and they were just doing really good, and our numbers went way up. And all of a sudden our numbers went down to the basement again. And I'm going, well, what's going on? Well, and so we had all these things that were clinical decision support, all these different kind of interventions. Well, what happened was the medical assistants who were doing this found out that every time they circled peak flow on the super bill, the patient was getting charged. And the patients weren't happy because they were being charged for this. The front desk, our staff never wanted to pay. They would give everything away if they could. I'm sure you all understand that. And so I, the manager, made the organizational decision that we weren't going to charge for peak flows any more than we charge for weighing a patient or taking their blood pressure. And so we made an organizational decision that although they circled peak flow on the bill, that it was not a charge. And then the numbers went back up. So those are just examples of how you can have a decision, you can encounter a barrier and can overcome it. But for a few minutes, let's talk theoretically about organizational support and remind you that organizational support falls in 3 areas: time, money, and personnel. And in the example we just looked at, leadership making a change in a personnel policy is one way to overcome the barrier, i.e. the leadership can say to the front desk, we're going to change our policy and you can make appointments for people even if it's not on the super bill. So when you're needing organizational support, you have to think as a QI group, what factors would motivate organizational leadership to assist in overcoming a barrier that you've encountered in a quality improvement initiative? Well, not to be too crass, but money always speaks. And so anytime there is a financial argument that can be used, you should use it. For example, the Quality Improvement Committee can work with the billing and coding people on ways to optimize the revenue through quality change. And we talked about this early on about PQRI benchmarks, and if you sign up for those, Medicare and Medicaid, you actually get higher levels of reimbursement. This is only going to increase with healthcare reform. There are going to be more and more ways that you can optimize your revenue through quality changes, and so that's going to be a real motivator for leadership and for you to find ways to optimize the quality so that you can improve your revenue streams never a bad thing. I mean, it's, you got to be able to make money. That's reasonable. Another thing, overcoming organizational barriers is the right thing to do. Um, you know, it's not all about money. Leadership wants the best for the patients and the employees just as much as they are concerned about the bottom line. So sometimes it's important to build an argument about doing the right thing. But I'm going to go back, and you've heard this, and my staff gets so tired of hearing this, but they still don't seem to believe me. You must have data. So you can't go to leadership and just tell stories. You have to have evidence that there's a quality problem and that you have a solution, but you need their support. And that support might require time, money, or personnel. So they want to do the right thing, but you have to have the data. You can't just say, I just know that all of our patients our diabetics are not well controlled, and you don't have the numbers. Or, patients can't get in for an acute problem. I just took over a new practice because I had nothing else to do. So student health, I just took over student health at the university, and one of the big things is that the students all say they can't get any, same-day appointments. And the clinic says, yes, they can. And so I've got these, he said, she said kind of things. And I said to the clinic staff, well, would you please start, keeping a record? Every time a person calls for a same-day appointment, make a note of it, and did they get it or not? Give me the data so that I know. And then if I've got evidence that shows that they are in fact getting same-day appointments, then we can do some sort of publicity or something and tell them how we're doing it. But I can't just get stories. I get this data from the students that says one thing, and I take it to the clinicians, and they say, well, that's not true. And I'm going, So I guess I'm one of those organizational leadership people now, and it's all about data. So I want to talk a few minutes about best practices, because assuming you have the data to support that you've got a problem, for example, according to your data registry, the practice patients have an average A1C of 8, and we all know that that's not adequate. I didn't want to make any lower a number because there's some debate about 7.5 or 7, but 8, there's no debate about that. 8 is too high. So how do you get this down? What are the evidence-based strategies to get this number down? And this is going back a lot to the whole quality improvement process. But the idea is you've got a problem, and how do you overcome potential barriers to introducing best practice? And in fact, interestingly, the students at our clinic recently encountered this whole issue with the A1Cs were not good, and so they had a quality improvement process going, and the first thing they did was a continuing education to all the staff about the new strategies for lowering A1C. I mean, the days of just metformin and sulfonylurea are long gone, although those are still important treatments, so don't think you have to spend a lot of money on your patients. But I'm not going to talk to you about how to treat diabetes. But one of the things they did was they took the ADA guidelines, and there's very nice algorithms on drug treatment in them, and they made copies of them and put them in places where the student providers would see them so that they would know what drug to start with, what dose to use, and just as reminders, bearing in mind that they are students. And it happens in this particular student-run clinic, there are a lot of students and very few physician or clinician preceptors. And so they have to know a lot to learn this on their own. Another thing you can do is talk to the providers to determine what they perceive as barriers, and we're going to talk about that in a few minutes, and then reward the providers who are making the most progress. It never hurts to acknowledge the people who are getting the best outcomes. Why not? Nowadays with these practice registries, you should be able to determine how well Jane Smith MP's A1Cs are compared to Dr. Jones MD's, or compared to Bruce Leonard's PA. And you know, a little competition isn't bad. It's reward the providers who are making the most progress. But let's talk about some provider barriers then. Now, I've heard all of these. And maybe your providers are great, I know providers are listening to this, and I don't mean to be insulting anybody, but in my world, I hear a lot of this. Now, not from everybody. I've got some amazing clinicians, but I have some, for example, they will say that it's not my fault, my patients won't do this. That's what the next session is about, so I'm not going to go into any detail about that, but it's sort of the barrier of it's not my fault. Another one is I'm really not comfortable with these new treatment plans. I don't like initiating insulin. Most of us as primary care providers really weren't brought up starting insulin for patients, and so we've not always been 100% comfortable with that. It's like you always send them, in my world, to a diabetes specialist to start insulin, and you know, you can't do that today. Today we have to start insulin, and you never could because you're out there in the sandhills and you don't have a diabetes specialist. But those are things that many providers, and it's not just nurse practitioners or PAs, physicians who've been practiced for 30 years and have been doing it a particular way, the new ways can be a little threatening. A lot of times, and I think this is a valid concern, that providers are really concerned about what the patient's being asked to do and how much it costs. I hear this all the time. You know, you're talking about going up to 3 medications. This is going to cost a lot of money. We're asking the patient to give themselves insulin, you know, before 2 meals a day and at bedtime. We're asking them to check their blood sugar 4 times a day. It's going to cost too much. And so I really do regularly hear from providers their concerns about the patients. And I think these, frankly, are probably not justified. I think if you involve the patients and gave them a choice, they really will do what has to be done for best care. And then my most favorite, I don't think that's good grammar, my personal favorite is that providers truly are desensitized to some of these measures. And I will hear, these are pretty good numbers from my patients, and you've probably heard those stories from me already, but in a world where people come into our clinic all the time with A1Cs in the double digits, 8 looks pretty darn good. And that's a barrier. It's not acceptable. It's not, you know, you can't just be satisfied with acceptable. You have to go to standard. And so that's something that we have to talk about as providers and make a commitment to. Just briefly, my clinical inertia slide, all of the things that we just talked about, those last 4 things, provider barriers, about not my fault, not comfortable with new treatment, concerned about the cost or the demand for the patient, and being desensitized, are examples of clinical inertia. And there's been some very interesting research about this inability for providers to and here's how it's defined, a failure of providers to intensify treatment in the face of evidence that it needs to be done. So a patient's blood pressure is 150/90. That's evidence that they need more intense treatment. Their blood sugar A1C is 8. They need more intense treatment, and they fail to do it. And there are many reasons, and those last 4 that we talked about are the main ones. And before I go in this, I want to mention, in fact, well, we can mention it with overcoming this, acknowledge this is an issue, have an open discussion about it. This is science. There's an evidence base about this. This is in the medical literature. And so it doesn't hurt to have an open discussion among the providers about this issue, that and let them talk about in a comfortable environment. I personally have never had trouble sitting down with my team and challenging them with, we need to get better outcomes, and letting them talk about these concerns and then working through. If you do it right, we're not insulting providers. We're not pointing fingers. Remember, quality improvement is always about systems. So have an open discussion about it, and sometimes that's all it needs. It really helps to have a provider champion for updated strategies. Somebody that says, I'm going to go. I just went to the AMA meeting on this, and I know how to do this, and you can come to me, and I'll help you with this new treatment or with this new thing. So anytime you can get a provider champion, that's great. And again, use a system approach. Don't put the fault on the provider. There are other ways. For example, the providers believe that their patients, they're asking too much for the patients. Well, they obviously haven't watched TV lately and seen all the commercials about, ask your doctor about this new treatment. Well, maybe, talk to the patients, provide some literature about diabetes, and make sure the literature says, here's what the goal should be. Your A1C should be X. And yours, and then, whoever's checking them in can hand them a piece of paper that says, here are our goals for your diabetes care, and here's where you are with that. And so your A1C is 8, and our goal is 7.0. And then at the bottom, say, ask your provider what you can do to get better numbers. Just like the signs that say, take your shoes off, and remind your provider to check your feet. And I've never been insulted by patients who say, things like, I want to see you wash your hands. It's okay to activate patients. And so that's a system approach where you give the patient some literature, and that overcomes that concern the provider has about, they don't really want to spend that extra money. Actually, they may be very open to these new treatments. So some other sort of summary solutions to practice barriers and how to overcome them. This is just like when we talk next time about the patients, that it requires ongoing and repetitive training. The entire practice needs relentless follow-up to keep going. So you can't introduce a new idea and expect it to become the norm. You have to just keep reinforcing it. You have to keep expecting it. You have to keep reminding people about it. You have to keep rewarding it, acknowledging it, or it's something you do for a week and then it falls off. And so it needs relentless follow-up, and that's what the quality improvement team has to do. Everybody has to be involved. Remember, all quality is about system issues, not individuals. It's not about one person. Nobody has a practice whose problem is one person. It's system issues. And I'm not saying that there aren't practices with one person who is an issue, but in general, they're system issues. Share results all the time. The quality improvement team shouldn't be a little group that meets off in a corner and then comes out with these ideas, and have a newsletter, have some sort of report at the monthly clinic meeting. Share results and use the data to motivate change and reward improvement. And think about this. When was the last time you evaluated anybody in your practice based on quality outcomes as opposed to other kinds of good performance, like, they've been there the longest, or they've good attendance, or, what about patient satisfaction is a reward, is a reason to give a raise, or perhaps one provider gets a higher raise than another because his or her A1Cs are better. It's something to think about, basing evaluations and rewards on quality outcomes. Not it's just a meritocracy idea rather than just, I've been here the longest and therefore I get paid the most. So these are some final points. Quality improvement requires a culture change in the practice, and until that happens, there's always going to be barriers. Well, there's always going to be barriers, but once it happens, they won't be as permanent, as problematic. Everyone must be involved. One person cannot make this happen. A champion or two can really help, but it can't be one person. It has to be a commitment of the organization. Leadership must come both from the top down and the bottom up, and relentless follow-up is essential. You just have to keep coming back to it. So often the barriers aren't so much the initial change, but the sustaining of the change. And we won't even talk about spread in this process, which is moving to, because spread is usually about making the change in a large organization, and none of you are really large organizations, so I'm not going to talk about that. But just sustaining change in your little practices requires all of these things: a culture of change, everybody involved, leadership at both the bottom and the top, and relentless follow-up. Thank you very much. If you have any questions, please contact me. And surprise, surprise, you have no assignments with this. I am going to get this last lecture out, and then I'm going to start setting up some opportunities. I'm getting your materials. You're sending them to me. That's great. And I'm going to be sending them all in for CEs and getting that out to you. But I'm going to send up some, identify some times to have some phone meetings or online conferencing using some of that free online stuff that we can use. So we will be talking, I hope, soon. Thank you very much, and have a nice rest of the day.